Hello, here's part two of the ethics of euthanasia. What we'll be looking at here today is the articles by James Rachels and Bonnie Steinbach, who are offering some more in-depth analysis about what exactly the distinction is that's being made when we talk about active versus passive euthanasia, why it is that professional organizations like the American Medical Association want to make that distinction, and whether it really holds up to moral scrutiny. So James Rachels, the author of the first reading, wants to argue that this is a false distinction that's being made between active and passive euthanasia. So in ethics, when we talk about a false distinction, what we mean is that we're claiming there's this difference between these two practices when really they're the same thing. So James Rachels' point and the argument that he's going to make in this text that you have is that there's really no moral difference between an act of passive euthanasia and an act of active euthanasia. So what he's responding to here in this text is the initial statement put forth by the American Medical Association in 1975. That one that we already looked at in the first video, the one that was created in response to the Karen Ann Quinlan case, in which they say that passive euthanasia is okay, it's a form of letting die, whereas active euthanasia is a form of killing. Rachels is saying there's no real moral difference between these two things. He's saying that letting die, if you just basically let a patient die of what we would call the disease itself, that is often less humane, he says. It's more painful, more difficult for the patient. And that he says we're responsible for the consequences in both instances. Because the consequence of our decision in both instances is the death of the patient, he's going to say for that reason they are morally equivalent. So he's going to give us some examples and of course, some premises to support his conclusion. So his two examples that we see in the textbook are first, the patient suffering from throat cancer that he gives on page 227, and second, the examples of Smith and Jones that are given on 229. So I want you to look at these and think about them and see if you think that these are good ways to illustrate Rachel's point that there's no real strong moral distinction between killing and letting die. So the patient with throat cancer on 227, I'm just going to read you a very brief excerpt to summarize that in case you don't remember. It's a real short case. He said, a patient who's dying of incurable cancer of the throat is in terrible pain and can no longer be satisfactorily alleviated. He's certain to die within a few days, even if present treatment is continued. But he doesn't want to go on living for those days since the pain is unbearable. So he asked the doctor for an end to it, and his family joins in on the request. Now, after this, he says the doctor agrees to withhold treatment, to not continue keeping him alive. But the doctor in this scenario that Rachel's is presenting doesn't want to actively end the patient's life. And his idea here says, James Rachel's idea here is that if one withholds treatment, it's going to take the patient longer to die and is therefore less humane. You're forcing that person to suffer for over a long period of time, even though death will be inevitable either way. So the idea here is to really get at the idea of suffering and humanitarianism, to think about what we ought to do out of compassion for the suffering patient who will die regardless of what we do, and to get us to think about whether there might be some instances in which it would actually be less humane, less good for the patient, to require them to die of natural causes, which takes more time, instead of alleviating their pain and suffering by helping them die earlier. That's what he's getting at with this first case of the throat cancer patient. The second example of Smith and Jones, given on page 229, is going to illustrate the notion of what we saw under utilitarianism of negative responsibility. So just to refresh your memory, this is something that I mentioned when we talked about utilitarianism. This is the notion that we are to be held responsible for the consequences of deciding not to take action, just as we are for the consequences of taking action. So in this example, we have two individuals, Smith and Jones. And they both stand to gain a large inheritance if anything should happen to their 6-year-old cousin. So here we have Smith. One evening while the child is taking his bath, Smith sneaks into the bathroom and drowns the child and then arranges things to look like an accident. Well, hopefully we would all say that Smith has definitely done something unethical there. We think that he's responsible for the death of the child. We would call him a murderer. He definitely killed the person. In the second instance, we have the same exact scenario. Jones stands to gain if anything should happen to his 6-year-old cousin. Like Smith, Jones sneaks in, planning to drown the child in his bath. However, just as he enters the bathroom, Jones sees the child slip and hit his head, fall face down in the water. Jones is delighted. He stands by, ready to push the child's head back under if it's necessary, but it's not necessary. With only a little thrashing about, the child drowns all by himself, accidentally, as Jones watches and does nothing. So Jones, in the second scenario, hasn't actually caused anyone's death. He appears on the scene, he sees that the child is drowning in the tub, and he just doesn't do anything. By proposing these two examples, James Rachels thinks that the readers would all agree that Jones is also morally despicable. Jones is just as responsible for the death of his little cousin drowning in the bath as Smith is in the first example, even though Jones didn't technically do anything. Jones is being held responsible by us for his decision not to act. He could easily have stepped in and saved the child, and he didn't. So the point Rachels wants to make here is that if we want to hold Jones responsible, if we want to say Jones is a bad person for not acting here because his inaction, his choice, led to his nephew's demise, then we would also have to say that doctors don't get to keep their hands clean morally by saying, well, I didn't kill the patient, I just let the patient die. So he's drawing a correlation here by giving us these examples of Smith and Jones to get us to think a little bit more about whether you really get off the hook morally by making a decision not to act. So Rachel's conclusion here is that because it's a false distinction between killing and letting die, or between active and passive euthanasia, that we really need to either allow both or prohibit both. He doesn't actually say it in this particular excerpt that you have, but he thinks we should allow both. The reason for that is because of the humanitarian concern that it might actually reduce suffering to perform acts of active euthanasia. So if we're going to prohibit both, we would at least be morally consistent, right? And so that would be better than this current distinction that we're making, which he doesn't think holds up. But better for him, in his own opinion, would be if we were to allow both. Okay, so this is James Rachel's basic rebuttal of the 1975 distinction that the American Medical Association made between active and passive euthanasia. This critique that Rachel's has also applies to the current standards, right? We saw that the American Medical Association changed a little terminology, but their stance is still the same. They allow withdrawing and withholding treatment as a form of letting die. They don't allow killing. The second author, Steinbach, is going to introduce a few more considerations that she thinks we need to take into account before we fully get on board with Rachel's critique. So the two distinctions that she wants us to make, that she thinks that James Rachel's has overlooked, is the difference between intended consequences and foreseeable consequences, and the distinction between ordinary and extraordinary treatment. So I'm going to talk about both of these in more detail. Let's talk about the distinction between intention and foresight, first of all. So in order to illustrate this example, I just have a quick case for you. We have a patient with a terminal condition that can't be cured, and he asks that all life-prolonging measures be stopped. His doctor complies, knowing that stopping the treatment will also lead to a quick death. So what we want to think about here is whether having foreknowledge of something, knowing before you do something what the consequences either definitely will be or are very likely to be, whether that's the same thing as intending, desiring those same consequences. So in this case, this very quick example, we have Dr. X who can foresee that patient A will die a quick death once these life-sustaining measures are withdrawn. But Dr. X doesn't intend to cause patient A to die. In other words, he doesn't want patient A to die. He's not doing it because he wants to cause patient A's death, even though he knows that will happen once he performs this action. So the questions that we would want to ask here is, if he does this and can foresee the consequences, does it matter that he doesn't intend or want them to happen? Or is he in fact morally responsible for his patient's death? So additionally, is there a morally significant distinction between foreseeing and intending? So some people think this is a very crucial distinction, that you can in fact anticipate consequences of your actions without intending them to happen. Other people think it's a false distinction, that if you know something will happen and you perform an act that you know will cause those consequences, by doing that you are showing your intention as well. Steinbach thinks that when we're talking about euthanasia, it is possible to foresee a patient's death without intending it to happen. So according to Steinbach, Dr. X here is not responsible for the patient's death, because even though he can foresee that as a consequence, he does not necessarily want it to happen. The other distinction that Steinbach wants us to think about is the difference between ordinary and extraordinary treatment. And this is going to get us back to some of those examples of those famous cases that I talked about in the first video. So extraordinary treatment, sometimes we call these heroic measures. These are usually expensive new technologies. Not always, but may sometimes cause a lot of discomfort to the patient in an effort to cure them or heal them. And extraordinary treatments usually are not guaranteed to be successful. There's some kind of gamble that you're taking by undergoing an extraordinary treatment. They may sometimes be experimental, although that's not necessarily the case. There are lots of very high technology, expensive ordinary treatments that are not experimental. Ordinary treatment's different. These are relatively inexpensive routine treatments. Something like getting a round of antibiotics for your infection, or getting your tonsils removed if you've had tonsillitis too many times. These are pretty ordinary routine things that are done very frequently and that aren't comparatively very expensive. These also cause minimal discomfort to the patient, so it's not a very large gamble to do them. And there's a very, very high likelihood of success. Because they're done routinely, we know very well how to do these things, and we know that they're very likely to be successful. So these are tested and known to be effective. So the issue here is that one procedure for a certain patient might be considered ordinary, and for another patient might be considered extraordinary. A great example of that is the ventilator. So if we're talking about the intended use of a ventilator as a temporary measure to help a patient breathe for a little bit until they're able to regain that function on their own, at this point in history, ventilators have been around for quite a while, and we would probably locate that in the category of ordinary treatment. However, sometimes that same procedure using a ventilator might be considered extraordinary in a case like Karen Ann Quinlan, a case where you've got a woman who's never going to recover and who is going to be on this ventilator for a long term. This might cause discomfort. It's not going to be successful because we know that she's not going to recover. So instead of thinking about categorizing different treatments as always ordinary or always extraordinary, we probably want to think about the circumstances in which that treatment's being used. Okay, so the question here as it relates to euthanasia is what counts as ordinary, extraordinary treatment? So we already talked about ventilators. They are pretty high tech. They're expensive, even though they are also pretty standard use in hospitals today. A big issue, though, is whether an IV and a feeding tube could ever qualify as extraordinary treatment. So the case of Terri Schiavo in 2005 in the United States was a great example of this debate between ordinary and extraordinary treatment. So the similarity between Schiavo and Quinlan, the other case that I talked about from 1975, is that Terri Schiavo was also in a persistent vegetative state, meaning that there was no possibility for her to recover and that only her brainstem was functioning. The difference, though, is that Terri Schiavo was not on a ventilator. She was able to breathe on her own, and the treatment that she was getting to sustain her own life was a feeding tube and an IV for fluids. So these are very low-tech interventions. These are things that are not experimental, are not particularly expensive, at least not in the short term. This is the treatment that Schiavo's husband was trying to have removed in order to allow her to die. So the big debate surrounding the Terri Schiavo case was, are these things so minimal, so ordinary, that it would never be okay to remove them? Or are, in this case, with a patient who's permanently unconscious, might we recategorize that as a form of extraordinary treatment? So in a lot of the hoopla and the controversy around the Terri Schiavo case, people were trying to sneak into her nursing facility with, like cookies and a soda. This is a woman who was not able to chew food. She was not able to swallow. That's why she was being sustained with a feeding tube and an IV. But the idea here is that maybe nutrition and hydration, just getting nutrients and water into your system, maybe that's so basic that everybody is owed that instead of just some people who are going to recover. Some people would say if there's no possibility of recovery now, those things have moved into this other category of extraordinary treatment. So the second author, Steinbach, wants us to think about that. And she thinks what's truly being distinguished in this American Medical Association statement is not passive versus active euthanasia, but rather the difference between ordinary and extraordinary treatment. And she reads that statement from the American Medical Association as saying, if something is routine and easily expected to help the patient get better, then we consider that ordinary and that you should always do that. But if something is not routine for some reason, because of an anomalous diagnosis like a persistent vegetative state or for some other reason, then maybe we're not obliged to continue that because it's extraordinary treatment. So some questions to think about as we go forward, and as you might want to start thinking about if you want to write a paper about this topic or for the final exam, whether doctors have different moral obligations than the general population. In other words, does the profession of medicine mean that doctors have a stronger obligation to help save lives, an obligation against doing things that might cause or allow death that we might allow other people to do? If I happen to walk by and I don't do CPR on someone, maybe I'm excused, whereas a doctor wouldn't be. A lot of people think that in this making this statement, the American Medical Association is really just trying to avoid legal liability. In other words, if they start allowing what's called active euthanasia, maybe they're just opening themselves up to be charged with murder or another crime. I want you guys to start thinking about whether you think there's a moral distinction, not a legal one, right? A moral distinction between killing and letting die, and whether you buy this idea that you can foresee but not intend the consequences of your actions. These are things that we will talk about later pertaining to other topics as well.